Okay, good. So we're all set. So we're recorded. So again, this exam will be on Thursday instead of tomorrow. And what I'll do is I'll have a tutoring session tomorrow, not today. I know I set up one for after this, but we'll do it tomorrow. Maybe a good time like 2:30 again. Can we do that, or you want? Can we do an early morning one, or you have another class?
Thursday we have class, I think 9 to 12:30.
So you're done at 12:30. So we can do a 1 o'clock maybe.
Sure.
Yeah, that's
Okay.
fine.
Okay, so Thursday, I'll resend another invitation for Thursday at 1, and we'll go over the focus points and all that. So 1 p.m.
Wait, so Thursday's
Wait.
tutoring, and when is the test?
Or
Oh,
do you mean tomorrow?
Yeah, I mean,
Uh,
Thursday.
yeah, okay, so,
Tuesday?
you want it on Friday, the test?
No.
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 Okay. All right, then I'll do the tutoring Tuesday. Did I say Thursday? Tuesday.
Yeah.
So Tuesday, so tomorrow is the tutoring, okay, 1 p.m. How is that? Or
That's fine.
Tomorrow,
Tuesday, right?
we only have funds on Thursday. I don't know about other classes, but we do not have funds tomorrow.
How
Yeah, I don't
about
have anything
it's
tomorrow.
better for, what's that?
I don't think
Yeah,
any of
I
us
can
have
do like
anything
any
tomorrow.
time tomorrow.
Okay, how about 9 o'clock in the morning tomorrow?
Okay.
Yeah, that's fine.
That works.
Fantastic. Let's do 9 a.m. tomorrow, tutoring for this class. Good. And then the exam is on Thursday, all day. So you can finish the, you know what, I'll open it up Thursday and Friday. How is that? And then whoever wants to take it on Thursday, that's fine. 2 days.
Thank you.
And then for the pharmacology, we'll do Saturday and Sunday again, like we did this weekend. So you'll have 2 days also. A little more flexibility for you. Okay?
Yep.
Dr. J, do we have class on Monday?
Yes. Oh, this Monday, what's
Holiday.
is there a holiday? Holiday,
Yeah.
what, which holiday?
Memorial Day.
Memorial Day, okay. Not thinking. I haven't read the emails, but I think, what did the other teacher tell you that we have a holiday?
I saw it online on the
Okay,
Roosevelt website
Okay,
that we
I'll
have that
confirm.
off, but I'm not sure. Okay.
I'll confirm. Okay, thanks for reminding me. If not, then, so Monday, holiday. Okay, I'll check on that and I'll let you guys know. Otherwise, yeah, we should be okay because we take the exams on different days than the lecture days, so which is good. So we'll be able to connect. So you guys take off the Monday. If it's should be Labor Day for me, you know, I'm a labor. Well, a lot of us are laborers anyway. So, but anyways, okay, sounds good. So let's do this. So tomorrow tutoring at 9 a.m. for this class. Exam will be on Thursday and Friday. We said, right? So exam Thursday and Friday, and then the pharmacology will do it on Saturday and Sunday. Exam. Sounds good. All right, so let's go ahead and finish up this chapter here. So we started talking about hypersensitivity type of reactions. Autoimmunity was one of them, and basically it's self-inflicted. Your immune system goes after yourself, after your own cells, in order to cause trouble, basically. We have, again, no single theory about this. There are a couple of theories that goes on, and polygenic, that means multiple genes are affected in this case. Multifactorial, that means different factors can cause autoimmunity. Therapy, we can immune suppress your immune system to slow it down a little bit. This way you can recover better with immunosuppressive. Corticosteroids, we said corticosteroids already from the previous lecture. It's an anti-immune, so it could be used in anti-immune. Cytotoxins, also some toxins that we can kill cells in general, the cells that we don't want. Tumor necrosis factor inhibitors and immunomodulators. We will talk about these type of drugs significantly in pharmacology when we get there, but in general, they suppress the immune system. Plasmapheresis, basically removing antibodies from the plasma. That could be another type of therapy that we can use for autoimmune. So these are some of the the theories that why would you get immune disorders. Again, anti-genetic, we just mentioned it briefly. We have the release of sequestrant antigens theory. That's self-antigen not in direct contact with the lymphocytes. So if you remember, the lymphocytes attaches to the antigens and they destroy them. So in this case, they say that the antigens, the particles, which are antigens, do not connect with the lymphocyte right. I mean, that's another theory here. T cell theories, we said that we have T cells and we have B cells. The T cells, the thymus is defected, decreased in suppressor T cells. Who wants to tell me what suppressor T cells do?
Do they turn off and on certain genes?
In a way, but they work basically on it's a T cell, but it suppresses the B cells to cause the plasma cells to create antibodies. So briefly, T cells stops the formation of antibodies by the plasma cells. So it controls it. Because as soon as we make a lot, then we go into autoimmunity. You see how it is? So autoimmunity, we have antibodies attacking us. So they say that we have a lot of antibodies being produced because the T suppressors are not working well. So the B cell let the plasma cell produces antibodies without any control. Are we good with this, you guys? Okay, so here's then also altered helper cells. Okay, anyone wants to guess what the T helpers do? So they're T cells that help the B cells produce antibodies. Isn't that something? So one cell suppresses antibodies, one cells help to create antibodies. HIV attacks the T helper cells, the CD4 cells. So you don't produce antibodies. Okay?
I have a question.
So the B, yes, please go ahead.
I thought the B cells were like, didn't they present an antibody or something?
No, the presenters are the natural killer ones. I mean
Natural killers.
The dendritic cells. Dendritic cells are the
Dendritic.
ones that presents the
Okay.
antigen.
Okay.
So dendritic cells presents the antigen to the T cells. Okay. So now question here: who creates antibodies? B cells or T cells?
B.
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 Yes. B. So B tells the plasma cells to create antibodies, to produce antibodies. Good. Now the T cells we have T helpers, T suppressors that also help the antibodies in either suppressing the antibodies or producing antibodies. T helper cells help the B cells to produce antibodies. T suppressor cells help the plasma cells to reduce the production of antibodies. Then we have the mast cells. So these are the ones that usually sends cytokines, and cytokines are signaling type of neurotransmitters to signal the activation of other cells, like the macrophages and all that.
Dr. J,
Yes.
which one was like, I guess the memory one that remembers like the
Yeah.
antibodies? Is that the under T cells or mast cells?
Yeah, we have actually two types of memory cells. We have a B memory cell, We have a T memory cell. So, the B memory cell, one of the B memory cells are the ones also that remembers. And then with that, after you produce the antibodies, those antibodies will go attack. And then we have a T memory cells also that plays a major role also with the T delayed sensitivity. We'll talk about it in a second. Okay. I mean, here, you want me to go back to the chart again? Let's go back to the chart, show you. All right, here you go. See this chart here? So B cells, right? You have memory cells here. You have the plasma cells here, right? So what does the plasma cells do again? They produce antibodies, right? So the B cells have memory cells, T cells have memory cells, and both remembers kind of what goes on. So, but the T memory cells are the ones that are more active in remembering things for later on to come and attack. All right. Make sure you guys know the chart that I gave you, the review chart. Let me show you which one is it. This. Okay, so here's, I mean, you need to know this by heart, which one comes out of what. So these are dendritic cells, macrophages comes out of the monocytes. Okay. So T cells, B cells, killer cells comes out of the lymphocytes. So put this chart down and make sure you know which cells comes out of which cell. Okay. Let's move forward. Okay. So risk factors, genetic factors for autoimmunity, they say that the major histocompatibility complex, MHC gene, which is HLA, so this is usually you have an issue with HLA in order to cause autoimmunity. So there's a complex on the cells that's made out of what we call HLA genes. So if you have issues with the HLA genes, then you have histocompatibility. That means the tissue is not compatible. So that's what the graft usually, histocompatibility. We do an HLA test on you to see if the tissue matches or not, to give you a graft. Okay, so that could be one of the genetic factors. The other is viral and bacterial infections also can cause the autoimmunity. And environmental and occupational, like stress, especially in genetically susceptible individuals, stress can lead to autoimmunity. They relate lupus to stress, by the way, a lot. And lupus is an autoimmune. So again, it's autoimmune, so immunosuppressive, corticosteroids, like we mentioned in a second here. So here's lupus. It's a chronically inflammatory autoimmune condition, may affect connective tissue of the body. All right, remission and exacerbations, stressors tend to trigger. So stress can trigger these type of symptoms here. These are some of the conditions here. The diagram will show you what are some of the things that you get. Now, around the face, you get like what we call a butterfly rash, which is this one here. If you notice, it's just looking like a butterfly. And this is a very typical sign of people with lupus. They get arthritis, they get Raynaud phenomena that, I will cover next class. This is when you have reduction in the oxygen supply reaching the fingers, and then your fingers will look so pale because you're not getting any enough RBCs in that area. So disease Progression varies from mild to severe, more common in women, Asians, and African Americans. Etiology and mechanisms. Etiology, we don't know why this thing happens. They relate it to risk factors, like we said, and they will also, the mechanism would be the B cells. The B cells are activated to produce autoantibodies and autoantigens also. They combine together and they form a complex which attack the body own tissue. So in this case, we got the antibody joining the antigen that is causing this problem, causing a complex, and then causing all these symptoms that you see in the patient. That's the possible mechanism.
Could you repeat that again?
Yeah, so we have the B cells, right? The B cells are producing what? They produce antibodies, correct? So the antibodies that what they do is they come and they look for the antigens that is causing this issue here. So you know, it could be pollution. It could be something that you are exposed to also. So in the case of stress, of course, you have, you know, increase in cortisol, right? And it causes damage to the tissue. So as soon as you see damage of a tissue, you will find, if you look at the tissue itself, a sample tissue, you'll find an antigen antibody complex of that tissue. So that tissue, the destroyed tissue, will become an antigen. So that part of the destroyed cells, which becomes an antigen, will join the antibody and forms what we call an antibody, autoantibody, autoantigen complex.
And that's only in the presence of stress, generally?
I'm just giving you an idea. So
Okay.
what does stress do to you? It increases your blood pressure. It damages cells, doesn't it?
Yes.
So when those cells that are damaged, okay, in your skin, in your whatever cells that are affected in this case and damaged, they become your antigens, correct?
Right, yeah.
So then the B cells will produce antibodies, and those antibodies, right, will join the antigens of that tissue to form a complex, and that complex sits there and messes up your homeostasis in general. So your tissue, your skin tissue is not normal anymore. Your kidney is not normal due to these complex type of formation.
Okay.
Okay. All right. So here's so lupus in general. These are some clinical manifestations for lupus. So we've got that means this is how you can diagnose these people. So serositis. Okay, serositis. You know, you have an inflammation usually inside the serum with these antibodies, right, and antigen complexes. So you'll see it. You have oral ulcers. You have arthritis, photosensitivity, blood disorders, renal involvement, immunological phenomena, anti-nuclear antibody. Now, this is what we look for when we diagnose lupus. Any autoimmune, you have to have, we look for this the complex that I just explained. So you look for these complexes, and these are called anti-nuclear antibody testing that we do.
Is that the ANA blood draw?
Yeah.
Oh, okay.
Yeah. Yep. So neurological
any kind of like autoimmune issue, you just draw for an ANA, nothing specific, or you get a positive and then you go specific?
Yeah, I mean, you look, all these autoimmune disorders like rheumatoid arthritis, like Graves' disease, like this one, lupus, you draw an ANA on the patient, right? So if you see, because they all form complexes, you know, antigen antibody complex. So if it's positive, that means you have an antigen antibody complex. So it's an autoimmune. You're going to say it's autoimmune. So it's a positive test for autoimmune disorders. So neurological disorders also, rash, which is the butterfly rash that I just mentioned, and desiccoid rash also. This is very red, you know, like a red type of rash that you get. So so that's what happens in this case. So all or some can happen with these patients. Now, it doesn't necessarily that you get all of them, but people with lupus can get any of these due to these complexes that we mentioned. So here's one of the diagnostic procedures that we do is the ESR, which is erythrocyte sedimentation rate, right? So this test you guys need to remember. You always do this test to diagnose for inflammations, okay? So this is a specific test for inflammation. So whenever you have an inflammation somewhere, like any type of inflammation, because when you have an immune system reaction, you're gonna end up having an inflammation. So ESR is a non-specific for inflammation. It's a test, but it's not always positive. It's not always positive only for inflammations. It could be positive for other issues also. But to confirm, we can do an ESR on people and then say, oh yeah, it's high. And this is like a sedimentation rate type of test where we look at how fast the RBC settles in the tube of blood. So if it settles fast, that means you don't have enough RBCs in that tube. So inflammation is positive. And you have a normal range for it. Okay. So just keep in mind ESR as a test. How come I don't have it listed here? This is actually the test. Let me see if I can. All right, just write down ESR. I'll fix it later on, you guys. ESR, erythrocyte sedimentation rate. Oh, here. It says elevated sedimentation rate, but it doesn't say. Write down between bracket ESR. All right. Good. Okay, so treatment and prognosis. So what do we do? Autoimmune here, right? So no cure. You know, people have lupus forever almost. You can stress manage people because, you know, stress has a lot to do with it. Health promotion behavior. Pharmacological, you can give them some NSAID, non-steroidal anti-inflammatory for this type of inflammation that they get. Anti-malarial drugs sometimes. Hydrochloroquine, the famous one that everybody knows now these days, could be one of the drugs. Corticosteroids, immunosuppressants, and DMARDs. These are specific drugs for immunosuppressants that probably we will cover when we talk about immunosuppressant drugs. And plasmapheresis. Plasmapheresis, again, taking antibodies from somebody else's plasma and seeing what's actually removing the antibody antigen complex to go ahead and if you have immune suppressant, usually we give this. So in this case, you know, I don't know how, you know, let me look this one up. Why would you use plasmapheresis for this? Because usually plasmapheresis is when you pull out antibodies and you treat other immune systems with it if you need antibodies. But in this case, I'll look it up and I'll let you guys know. So prognosis, improve with early diagnosis and treatment. So again, you improve, but it doesn't go away.
Would you, Dr. J?
Yeah.
Would you use plasmapheresis because it's an autoimmune disorder, so your body's attacking itself, so to put in fresh plasma to help your immune system?
Thanks. Yeah, it makes sense. Very good, Gandhi. Yeah, I mean, you're destroying your antibodies. Yeah, now you have less antibodies and you give it. You see how simple it is? Good job, Gandhi. I'm proud of you.
Thank you.
All right, moving on. See, when I can't function, you can function. You can help me out here. So which
wait,
genetic aspect? Yes, go ahead. Go ahead.
Sorry. What would the DMARDs again?
Which one?
The
DMARDs?
ARDs?
Yeah, these are different types of drugs that you use for immunosuppressant drugs, immunosuppressant issues in general.
What does it stand for?
Honestly, I don't know exactly. So
Okay.
we'll, I don't want to really, give you the wrong,
No,
abbreviations here.
I can
Yeah,
consult the
yeah.
Google
So
for that.
we'll look them up. You can look them up and let us know in a second. If you have
A disease-modifying anti-rheumatoid drug.
there we go. Thank you.
Okay.
Thank you.
Thank you.
That's it. See, we work as a group here, So fantastic. Okay. So you are using this actually for different types of, they're modulators, they help your immune system. And in this case, rheumatoid, it's very famous for rheumatoid arthritis. That's correct. All right, what else? Let's move on into questions here. Which genetic aspect is associated with the development of autoimmune disease? These are the MHC genes that we have on our cells. So every cell has an MHC gene that, basically grabs the antigen, if you remember, and send it to the lymphocyte. All right.
Is that the same MHC that's broken down when you do a CBC analysis?
Yeah, when you do CBC analysis,
It gives you like your WBC, RBC, MHC.
that's differential though. Differential diagnosis, DCD probably, DCC. Differential blood. So differential.
Result for an MHC.
No, there's we'll get to the different blood cells in a second here, but MHC is the the histocompatibility type of the genes that we just covered a second ago. The CBC has a differential blood count.
Oh, it's a
differential blood count. DBC. Yeah, DBC, differential blood count. That's where you go in.
And then we have MCH. Sorry.
MCH. Okay, that's a different one here, which is it has something to do with
that's the amount of hemoglobin per cell.
Yes, hemoglobin. Yes, you're right. Mm-hmm. Okay, so hypersensitivity in general, we have normal immune responses. We have so again, hypersensitivity, too much hypersensitivity within your immune system. Normal responses, that is either inappropriately triggered, excessive, produced undesirable effect on the body also. So did I press record, by the way?
Yes.
Okay,
Yes.
thank you. Good. All right, a basic mechanism for hypersensitivity, specific antigen antibody reaction. So these are the antibodies that, we said you form usually when you have an immune reaction. They're called antigen antibody, right, complex, specifically with the humoral immune reaction. So this happens, and then you cause, issues with hypersensitivities. So usually these hypersensitivities are divided into 4 different types. We'll talk about each one. So 1, 2, 3, and 4. 1, 2, and 3 is mediated by antibody-produced B cells, where type 4 is mediated by T cells. So type 1, 2, and 3, the problem with this is a hyperactivity of the B lymphocytes in general. So you got a bunch of antibodies going on here, and the T cell has something to do with the number 4, the 4th hypersensitivity type. It has something to do with the T cell. So let's look at one at a time. This one, type 1, is referred to as immediate hypersensitivity. That means it happens right away, immediately. So when you get this type of hypersensitivity, if you're allergic to something, you contact contact is 2. But let's say that all of a sudden you're sensitive to you know, anything that you know, like in the air, you know, pollution or something, and all of a sudden, you know, like allergen also. Then you produce, you kick in, you know, what kicks in is your immunoglobulin E response. So immunoglobulin E is an immunoglobulin, and we know it's like it behaves like an antibody. So in this case, we have IgE involved in this reaction. So it happens within 15 to 30 minutes after the exposure. So when you get exposed to the, you know, dust, pollen, whatever that you breathe in, you end up having what we call increase in IgE. And that is very significant with type 1 hypersensitivity. So we have mast cells being involved in this case, and we said mast cells produces histamine. So when mast cells produces histamine, you're going to get all kind of histamine reactions that, or you know, effect that we just covered. So you know, in pharmacology. So it has something to do, it creates what we call an IgE Fc receptor type of linkage. And you find the Fc receptors usually on the cells also. So on our cells, we have multiple receptors, a lot of receptors, believe it or not. So in this case, we have the Fc receptor connecting with the IgE receptor. You have increased in intracellular calcium, and that is one thing that you need to keep in mind. So you have that increase in calcium will immediately cause local mast cells degranulation, and pro-inflammatory mediators comes in, and then you have all the histamine coming out to cause the vasodilation and the increased vascular permeability and increased mucus and all that stuff that we just covered when we talked about antihistamines. So we have also prolytic enzymes. Okay, these are the ones that activate kinase pathway. If you remember, kinase pathway are the signals that sends and calls on the macrophages to come and help out. Chemotactic factors, and these are the ones that recruit or activate other cells by signaling them also. So you have signaling pathways taking place in this case in type 1 hypersensitivity. So you need to know mast cells are involved, histamine comes out of mast cells, calcium deposits are, it will form inside the cells. And so that's what happens usually with type 1 hypersensitivity. And it's due to, you know, allergens like dust, pollens, and all that. Okay, so let's, clinical manifestation, we have mild. You get hives, seasonal allergies, eczema. Okay, and eczema is a very dry scaled type of lesion on the skin. More problematic symptoms, that would be throat constriction, and so some people, they just go into you know, their airway constrict and they can't breathe because of the allergies, and that's type 1. So allergic rhinitis is the famous one that you get from pollen, dust, and all that. So localized edema, wheezing, tachycardia could be in severe conditions. You can get that. Anaphylaxis, that's a life-threatening situation. That's when you really you need to help people right away with an EpiPen or something, otherwise they can die because it hits their respiratory and then the heart, then you become brain dead after that. So you need to get them right away immediately when they cause this. So as soon as they start swelling their face and they complain of shortness of breath, that means you need to take them into the ER and get an epinephrine on them. So here we go. Epinephrine sits all the way on the bottom. That's in anaphylactic reactions. But meanwhile, so you can use antihistamines, the ones that we talked about today. Beta adrenergics, which causes bronchoconstriction, decreases bronchoconstriction. So bronchodilation. It causes bronchodilation. Okay. So, and then we have corticosteroids, anticholinergic drugs, Ig therapy also, which inhibit binding the Ig to the mast cells with the Fc receptors there, so they don't connect together. All right, type 2, again, sometimes immediate, but sometimes it happens over time later on. This is known as tissue-specific, cytotoxic, cytolytic hypersensitivity. So it's tissue-specific. That means it depends on the tissue that you have. And the cytotoxicity, when you get different things like anything that comes and you reject it, so that would be a tissue specific. Cytotoxic, it means any cells that are toxic to you, and any foreign cells that you introduce to other people, that is referred to as cytotoxic. In this case, just think of graft, giving somebody some kind of graft would be probably this type of sensitivity here. All right, antibody attack antigens on the surface of specific cells or tissue causing lysis. So you have antibodies that can, attacking the cells and causing lysis of the cells. Lysis, it means destruction of the cell. So it could be mediated by activated complement fragments also. So these complement fragments are sitting on the top of the cells. And okay, one more time. We have what we call complements, right? Anybody knows what a complement is? Have you guys heard of complements? It's referred to as a complement cascade.
Aren't those involved in the immune response?
Okay. One more time. Is this Gabi?
Yeah, I just was
Yeah, go
asking,
ahead.
are those involved in? I don't know if it's active or not active, innate or the other one, but I thought they were involved in the immune response.
Yeah, they are. They're
Complement.
specific
Okay.
proteins. Yes, absolutely. You're right. So these are the complements. What they do is they're some type of proteins, okay, that drills holes into, like bacteria or any cells that, that you don't want. And they attack the bacteria using their MAC complex. So it's like a drill. The MAC complex is a drill that sits on the complement. So this is usually are activated when I give you a graft. So if I give you a graft that don't match your body, right away the complements comes in and start attacking those cells, and they start lysing the cells, and it forms a type 2 hypersensitivity type of reaction. So hyperacute graft or blood rejection can cause this type of hypersensitivity. Hemolytic disease of the newborn. Anybody ever heard of that before?
Yeah, it's just a phenomenon when the fetus is exposed to RH factor to RH, and there's a adverse effect depending on whether the mom has the antibody or not.
Absolutely, yeah. It's called erythroblastosis fetalis also. So hemolytic disease of a newborn, that's when you have an RH negative mother marrying an RH positive dad and ending up having a fetus that is RH positive like the dad. Then the mother will start developing antibodies against her own fetus because she doesn't have antibodies because she's negative, and eventually killing her baby. And usually this happens to the second baby, not the first one, because it takes roughly about 8 months to 9 months for those antibodies to develop and kill. So we give those patients Rogam, if you remember, which is a gamma globulin M. How about myasthenia gravis? What is that? What's the issue with this one?
Would it be like extreme like muscle weakness? Or?
Yes, you have muscle weakness, specifically, skeletal and some smooth also. And these are, it's caused by what? What deficiency of what neurotransmitter?
Acetylcholine.
Good job. Acetylcholine. So you have deficiency in acetylcholine, and you end up having this disorder. All right, so we're still on type 2. So you have blood transfusion reactions also can give you blood type 2. So if you receive the wrong blood type, eventually you're going to end up creating what we call a type 2 hypersensitivity reaction. And usually a recipient of the wrong antibody will come and form a complex with the antigens of your antigen, whatever your type is, and causes this type of reaction. So acute transfusion reaction usually happens within 24 hours of the blood transfusion. Usually you get fever, chills, pertus. Anybody knows what pertus is?
Itching?
Itching, yes. And itching due to increase in what, do you think?
Histamine.
What is it? Histamine?
Histamine.
Histamine, yes. Histamine. And then urticaria, which is hives, typically resolves promptly without specific treatment or complication. So, it goes away, but in severe conditions, sometimes if it causes like other type of like breathing problems and so on, then epinephrine comes in, you got to help them out. So here's the hemolytic disease of the newborn, the one we just talked about. And I just explained that briefly. So again, Rh negative mother, Rh positive father, Rh positive baby. The mother creates antibodies and you end up having a baby that looks like this, dead baby, when they come out because of that. So you give them Rh0 GAM for immunoglobulin M. Okay, that's what you give in order to avoid this. So we test you before you get pregnant. If you're Rh negative, you need to be always tested. Otherwise, if you're going to deliver again, you need to be placed on RhoGAM before you get pregnant. So if you're an Rh negative mother and your husband or boyfriend, whoever your mate is Rh positive, you better get tested just to make sure that you're negative. And if you want to have a baby, you got to go on RhoGAM. So here we go.
Can it be administered? Oh, sorry. Can it be administered during pregnancy?
Yes, it can. It can. Usually we do. So there are a lot of women, they don't get tested, right? So they walk in and they come, we do a blood test on them and we find out they're Rh negative. So we give it to them anyways. And if it's the first pregnancy, it's great. They should be fine. You give it to them anyways, right? Just to be protected, and they come out of it.
Sure.
But
okay.
Yeah, on the second baby, when they come, you try to give it to them, but sometimes it works, sometimes it doesn't. It depends on the baby.
So it doesn't. I guess it doesn't matter even if it's pre or during pregnancy.
Yeah, but you preferably before. Then she'll be protected definitely with those immunoglobulins.
Okay.
And she doesn't have to worry about creating the immunoglobulins here.
Got it. Okay. Thank you.
All right. So myasthenia. You're welcome. So myasthenia gravis. We just talked about it a second ago, and it has something to do with the neuromuscular junction where the nerve meets a muscle, And right there, that's where you produce, you send in your acetylcholine to cause contraction of the muscle. And with this case, if you're missing acetylcholine, so you're not going to contract, and it's going to be a loose muscle. So people will have difficulty in swallowing. You know, people with myasthenia gravis will have difficulty in swallowing. So when you give them something to eat, it gets stuck in their throat because you don't have that peristalsis mechanism in their throat. And they have loose muscles everywhere in their body also. So eventually they die. You give them acetylcholine, of course, you know, that's what you give them. But eventually they don't last long because, you know, it's all over their body, and the amount of acetylcholine that they need is huge. And we can't overdose them with them because, you know, you end up having lots of side effects from acetylcholine. So Graves' disease is the other one. And what is Graves' disease again, you guys? Anyone? It has something to do with what? Which gland?
Your thyroid.
Thyroid, absolutely. So hyperthyroidism, basically, autoimmune hyperthyroidism. Also along with lymphocytic thyroiditis, you know, both have autoimmunity. Neutrophils bind to target cells. So the neutrophils goes bind to the, in this case, the thyroid cells, block receptors from normal functioning, causing injury to or malfunction of involved tissue. Okay, so that's what happens usually when you have, Graves' disease eventually, because you're not going to have functioning thyroid hormones. You're going to have increase in thyroid hormones in the blood, but it's not functioning. You know, your metabolism is not normal. It's hypermetabolism. You're going to end up having hypermetabolism because your thyroid will be producing plenty of thyroid hormone, getting a negative feedback because your metabolism is not kicking in. So eventually you're going to end up having hypermetabolism because of that. You have also hyperacute graft. We just talked about it, how graft can cause this issue also. All right, when we get to 3, 3 is different a little bit. So 3, again, we cause an immune complex reaction. But here we have the phagocyte, and phagocyte system fails to effectively remove the antigen and the antibody immune complexes. So again, we said those complexes, the antigen and the antibody complex, can cause problems to this normal tissue to function well. So here comes your phagocytes. They come and they eat up and they engulf all these complexes that we create. So if you have an issue with your phagocytes, then you're not going to be able to take the antigen antibody out of there, and then you have a severe hypersensitivity there. Usually, if you look at the tissue under the microscope, you're going to see deposits of antigen antibody complexes right there sitting there in the tissue. You're going to activate the complement to come and start destroying these things. And then self-sustained inflammation. Usually it comes in a few hours, several hours or longer after this reaction happens. So, and sometimes it's ongoing kind of issue here. So that's the mechanism. Let's look at some of, the causes. So here's the complex. This is what we're talking about, these complexes forming on. So for example, the kidney can have an issue that is this buildup of complexes can sit in the nephron, cells, the basement membrane of the kidney. When they sit there, they close up the filtration process. So the cell will not, the nephrons will not be able to filter. And so that is one type of one type of type 3 type of allergic reactions. So the type 3, you have a buildup of complexes on the basement membrane. Specifically here, we're talking about the nephrons. And when this happens, then you have what we call large complexes, very large complexes. So they will be fixed or marked by the complements, and then they are transported to the liver, where they are phagocytes. So complements and phagocytes, complements comes and destroys them. Then phagocytes comes in and picks up those complexes, the antibody antigen complexes, send them to the liver to destroy them. So they can also become stuck in the kidney, unable to cross the glomerular basement membrane. So filtration. So you can see the picture here where they sit right there, and then you have no filtration taking place when these things sits on the basement membrane of the nephron. So we have either very large complexes, or we can have intermediate complexes or small complexes. So the intermediate size is intermediate, medium. These don't fit the complement cascade well, so it doesn't help fixate this complex. They do not bind to the red blood cells as well, are not removed by the mononuclear phagocytes, which is the phagocytes themselves. So we can look at this diagram and see how, here we have intermediate size immune complexes depositing right there. These are the intermediate. Then we have the complement being activated, going in to start destroying it. And then we have lysosomes also coming to break it. And then we have things like enzymes. All these are reacting in this case, but this complex will get stuck and it will sit on the membrane eventually and causes, no filtration taking place. So on the test, if I ask you which one involves, different types of sizes of complexes attacking, being helped by the complements, cascade and lysosomes and all that, trying to resolve this issue, then you say type 3. So immune complex glomerulonephritis is one disorder that you can get these things. Inflammatory renal disorder, typically 10 to 2 weeks after streptococcus or staphylococcus infection. This is very important. So I'll give you a clinical scenario where someone came in after having streptococcus or staphylococcus infection, caused one type of hypersensitivity disorder. Which of the following is the type? Then you pick type 3. So systemic lupus, we know we mentioned it under what, 2 before? And now this one when it's more severe, okay, where you have actually heart complications also with it. So it could be, we could have type 2. It's more of a type 2 than 3, but once in a while you get a type 3 on lupus. So, but which is more frequent, 2 or 3? I would say 2, but it could have a mechanism of 3 also once in a while. In this case, yeah.
I don't think systemic lupus erythro happens with type 2 hypersensitivity.
What did we say?
I think it's just an autoimmune. It's not under there.
Oh, okay. When we mentioned it earlier as an autoimmune. Okay, yeah. Okay. I'm saying 2. I don't know why I was saying. Thank you, Stephanie, for correcting me here. Yeah, it's an autoimmune. So instead of being autoimmune, sometimes it's caused by 3. That's where we're going with that. I kept saying 2 instead of autoimmune. Correct. Very good, you guys. Very, yeah. All right, so here's 4 again. It's a delayed hypersensitivity. That means it doesn't happen immediately. Happens after several days sometimes. That's where you see the signs and symptoms. And so poison ivy, TB testing also could fit under 4. So if you have poison ivy, you get scratched by the plant, maybe walking around between plants and so on. And then eventually you will see the reaction on the skin a couple of days after. So so that's what it's a delayed type of cell mediated, because it has something to do with the T cell memory cells. So the T cells memory cells kind of remember the reaction, remember that poison ivy, and then it will cause the signs symptoms later on in time. Okay, so it's a delayed cell mediated response. That's where we want to go with that. So we have tissue damage resulting from a delayed cell reaction. Sensitized T cells, these are the ones that basically interact with the dendritic cells that we have, again, where you produce introduce the antigens to the T cells, and react with hapten. These haptens also are a type of substances that that are initiated through inflammation usually. So you have hapten cells. You have the sensitized T cells are the ones that are activated by the dendritic cells. So in this case, if we say which of the following involves hapten molecules, which are very small, incomplete antigens. That's what we mean by hapten cells. So hapten cells are antigens. We said they're fragments of the cells, actually a DNA, fragments of proteins. That would be the antigen. And then hapten cells would be an incomplete antigen. So an antigen looks at a certain shape, and then if you have an incomplete antigen, that is referred to as a hapten molecule. So hapten, T cells, memory, delayed hypersensitivity, you put them all together in this kind of sensitivity reaction. So contact hypersensitivity, contact dermatitis in this case, like poison ivy. If you're allergic to nickel or anything that you put on your body, then you have a reaction. Usually it shows later on after a couple of days. And slow reaction, so the hapten again, very small, incomplete antigen, becomes complete antigens when attached to the carrier. So they change into a complete antigen when they attach to a carrier that takes them into the infected cells or affected cells. So we have another one that's called cutaneous basophil hypersensitivity. Cutaneous means skin. Basophils are the cells, the WBCs. Hypersensitivity, so here we have basophils being involved. This is the most rapid type 4. You have skin swelling, and you have skin graft reactions and rejections can actually fit also under this one too. Okay, so let's go into TB. This is the test that you guys get, the PPD. They inject you with a little live type of attenuated, very, very weakened bacteria, TB bacteria, tuberculosis. And then you wait, they tell you to come after a week, because nothing will happen, no reaction will happen at the beginning, because you need those T cell memory to come and remember what they are and react against them. So that reaction happens after 48 to 72 hours. So you need to wait on that. You end up having what we call redness because of this. Anybody ever had the TV shot already? You probably did, all of you, huh?
Yeah.
Yes.
Yeah, TPD. So you notice at the beginning nothing, then after they tell you to come back to read it, usually that's how long it takes for a reaction to come and happen. So a type 4 hypersensitivity type of reaction. So you get redness, induration, and inflammation. Anybody knows what induration means?
Like the swelling around the area.
The size. Yeah, the size of the swelling, correct. Or the redness, the inflammation that you get.
So that's what they measure, right?
Yeah, they measure it. Absolutely, they measure. How many millimeters is it? Good job. All right, another one is granulomatosis, granulomatous hypersensitivity. So you have granules actually being involved in this case. So you have granuloma. How is that? So granulomas are being involved. Those granulomas are scar tissue. So you're going to end up having scar tissue, like round coin shape kind of granuloma on the tissue. It could be anywhere. It could be on your lungs. It could be somewhere else. So when you have granulomas being built up in your tissue due to this type of hypersensitivity disorder, you have like a, it looks like a Swiss cheese type of scar that you have inside your lungs. You could have it inside your lungs. So antigens is not destroyed within the macrophages. So you have failure of the lysosomes to phagocyte the antigens. So, so we have primary defense against intracellular infections, protective defense reaction that actually eventually causes tissue destruction. All right, which of the following disorders displays these characteristics? Failure to remove antigen-antibody complex, tissue specific, not tissue specific, include antibodies, occur over several hours or days, also called immune complex reaction. So the answer is C here, it's already bolded. So, so the one that takes hours, you know, days for it to come would be 3. All right, let's look at hyposensitivity. Hyposensitivity, that means you are undersensitive. You're not very sensitive to certain things. Usually results from functional decrease in one or more component of the immune system. So you have lower antibodies, lower defense in general. So congenital disorders and bone marrow defects are very, very common in this kind of issue. So the baby is born with immune compromise. We call that immune compromise type of sensitivity. Predisposed to multiple immune deficiency. The primary is congenital, coming from a bone marrow specifically. Predisposed to multiple immune deficiencies. So you have other immune deficiency disorders that's causing this as you are born, basically, or when you are young, when it's caused by multiple immune deficiencies. Secondary, usually non-immune system disorders. So, for example, radiation can cause immune suppression. Treatment that secondarily affect the immune system. So any types of medication sometimes can lead to immunosuppressants, like immunomodulators can lead to that. So it can affect the lymphocytes, antibody, phagocytes, complements, protein, all that. So which of the people that are at risk of immune dysfunction? Young people, very young, very old, poor nutrition, impaired skin integrity. What is that?
Like open sores, skin that's not intact.
Yes. burn people are very impaired. You need to be careful with these guys. So circulatory issues, alteration in normal flora due to antibiotic therapy. We know you should not overdose in antibiotics, don't you? And if you overdose with that, then you kill the normal flora and then you have issues. Chronic diseases, especially diabetes mellitus, people with diabetics, their immune, that's why we're protecting people like me from COVID. You know, you can easily, you know, because our immune system is down and we can get COVID faster. All right, corticosteroid therapy also, chemotherapy, smoking, alcohol consumptions, and immunodeficiency type of issues. All right, immune building strategies. How do you build your immunity? Well, increase fluid intake. That's why they tell you keep drinking water. Eating a well-balanced diet. Yeah, it's very, very good if you do that. The chicken and veggies and all the good stuff. Increasing antioxidants. What are antioxidants? What do they do? They block what?
They block oxidizing agents that would decrease normal flora.
Absolutely. So oxidizing agent, anything that gets oxidized, you know, in organic, you're going to cover it probably. Are you taking organic next quarter or something? I'm not sure. Anyways, we talk about oxidizing agents to oxidize certain things. When you oxidize certain things, you add oxygen to it. And too much oxygen can burn, by the way. Think of it this way. See that? So oxidation is adding oxygen. When you oxidize an apple, if you leave an apple open, right? What happened to it? It gets oxidized. And what happened to the tissue? It turns what? What color?
Brown.
Brown. So that's oxidation. So it, you know, when you build your immunity, you decrease the oxidants, and so you increase antioxidants and protein intakes. Getting adequate sleep is good. Avoiding caffeine and refined sugar. Caffeine. Maybe I should stop drinking caffeine here. I can't. Spending time outdoors. Running, jogging, reducing stress. Okay. If we tell you to reduce your stress, what do? You go ahead and work out, don't you? That's good. All right. Let's talk about B cell and T cell combined disorders. So we have issues with both the B cell and the T cell. So we said B cells produces what? What cells?
Antibodies?
Yes, eventually, but B cells produces plasma cells. Plasma cells produces antibodies. That's the order. So indirectly, B cells produces antibodies. T cells, what do?
Assist with the process.
Yeah, they assist in
Either
the
like
process
suppress or support production
of antibodies. Yes, some of them. And some are what? Some are straightforward what? Like phagocytes.
like the
correct?
killer T cells. Yeah.
Yeah, the killer T cells and the neutrophils. The neutrophils are the major phagocytes that we have in our body. So neutrophils, you know, they are a major type of you know, cells that we produce that basically they're referred to as lymphoid cells. So we have a disorder that's primary, that we have a combined T cell and B cell together. What are the disorders? The number one disorder is called severe combined immune deficiency disorder. Well, severe combined, it's telling you it's a combined disorder. So we combine both the T cells problems and the B cells problems. It's an inherited disorder. We have impaired T and B cells, right? Which help you in adaptive immunity later on. And it's characterized by severe immune system dysfunction and a variety of clinical features. So you do not produce good B cells and T cells. You got an issue, don't you? Major issue. Wiskott-Aldrich syndrome. This is an X-linked immune deficiency disorder that affects both T cells and B cells. So this is an X-linked. What did we say X-linked means?
Doesn't it always occur in men?
So the alphabet X is specific for the X chromosome, guys. That's what X-linked means. So you must have a gene, an abnormal gene, where? On the X chromosome. That's what X-linked means. It's linked to the X chromosome. So where's this disorder? Where's this gene at? Is on the X chromosome. Okay, on the DNA inside the chromosome. So this is called Wiskott and Aldrich type of syndrome. Now, T cell only. So we did what? B cell and T cell combined. What are they? Severe combined and Wiskott-Aldrich. Now, which one is the T cell only? We have DiGeorge syndrome and we have chronic mucocutaneous candidiasis. So let's talk about DiGeorge. DiGeorge is a T cell disorder. So what happens here? You have a problem with the thymus gland. So when you're born with a thymus gland, don't you? So when you're born with a thymus gland, what's the function of the thymus gland? Anybody?
Your immunity, it helps with your immune system.
It does, but
Yeah, doesn't
how?
it like develop the immune system?
Yes. Your T cells. Go ahead. Who was going to say something?
Produces T cells?
It matures T cells. Okay, it matures it. So who produces T cells, by the way?
Isn't that your bone marrow?
Bone marrow produces all the cells, right? So your bone marrow cell, the T cell, will go to your thymus and matures there up to age what?
Is it 9 or 12?
About 5 years old. Yeah, 5. So after 5, your thymus goes away. It dissolves so small where it becomes either a nodule or nothing. If it becomes a nodule, there's a chance of you getting what we call thymoma later on in age. So that means what? A tumor, benign tumor of the thymus. But if it goes away, vanishes, then it's better for you. So who takes over maturity of the T cells after that? After the thymus goes, when you get an adult, become an adult.
The bone marrow.
The what? Not the bone marrow, but who? We're not going backwards, we're going forward. So from a thymus, then who takes over?
Is it the thyroid?
No, the thyroid has the thyroid hormones and all that. After that, your lymphatic system takes over, in the lymph nodes and all that. So that's where they mature. So after the thymus, then the lymph nodes takes over in maturing the T cells. All right, so this disorder, that's called DiGeorge for T cells, basically, and also known as chromosome 22q11.2 deletion syndrome. So this is we have a deletion on the chromosome number 22 at the Q arm at exactly 11.2 region. So here they're telling you exactly where the deletion is. And if you have a deletion, that means you have an issue. And in this case, when you have a deletion, then you're going to end up with T cell problems. Often associated with other congenital problems like chronic mucocutaneous, associated with other congenital problems. Okay, we're done. Chronic mucocutaneous candidiasis. Candida is what?
Overgrowth of yeast or flora?
Yeast.
Yeast,
What is
overgrowth of yeast.
So yeast infections. When you have yeast infections, it's fungus, isn't it? Yeast and fungus, fungus gonna come out of yeast. So yeast infection, Candida albicans, right? That's the major yeast organism that causes, or fungal organism that causes candidiasis. So chronic mucocutaneous candidiasis. So you end up having candida, right? Because of that, and usually it's selective deficiency in cell-mediated immunity. Okay, so again, T cell involved in this case. So it's an autosomal dominant deficiency. Again, what does autosomal means? Dominant. If you're autosomal dominant, you're going to show in every generation, isn't it? So you can, if both have it. If your mother and father have this, you will show the characteristics in this case. In this case, you have immunodeficiency due to candida. So you have an immune deficiency, and you're going to end up building what? Candida. So yeast comes in for what purpose? People that have immune deficiency, you're going to build up Candida albicans. And that's what's going on. So you have yeast infection due to your immune deficiency. That's where we're going with this. So you call that what? Chronic mucocutaneous candidiasis due to deficiency in T cells. All right, B cells only. IgA deficiency. Immunoglobulin A is an antibody. It's just, sometimes we call them immunoglobulins, sometimes we call them antibodies. Antibodies is a general term for all kind of antibodies, but immunoglobulins, we have specific antibodies there. One is called immunoglobulin A, B, D, E, and M, and G. So these are specific antibodies. They're called what? Immunoglobulins. So immunoglobulin A deficiency, this is the most common B cell primary. So because we know antibodies are produced by what? Plasma cells, right? That comes out of the B cells. So immunoglobulins comes out of the plasma cell. Most common B cell primary immune deficiency disorder. Immunoglobulin A bearing lymphocyte failed to become plasma cells. So what's happening here? What type of lymphocytes fails? B or T?
B.
B.
So you have B lymphocytes failing to become plasma cells to produce immunoglobulin A. That's where the issue is, resulting in a lack of serum and secretory IgA. So IgA, usually it helps you secrete things. So when you are secreting things in your body, enzymes, secretions, all that, you need immunoglobulin A. So if you don't have immunoglobulin A, so you're not going to secrete things well. You need immunoglobulin A to secrete things out of your intestine, out of your bronchial tree, all that. Those secretions that you have in your body are IgA dependent. That's the function of IgA. The other one is Burton X-linked A-gamma globulinemia. So this is what? Globulinemia. So Burton X, where do you find it again? This one, on the X-link, on the X chromosome. So Burton, this is easy. Just remember B for B. How is that? So Burton is B cells. So this is A-gamma globulinemia. What does that mean?
Low production of
gamma globulins, right? So A without, correct? Gamma are the immunoglobulins. The type of globulins in this case are gamma. So you have reduction in the gamma globulins. So again, gamma globulins are antibodies, specific antibodies that are produced by the B cells. So in this case you have, and this is a congenital issue, it's X-linked, you're born with this, and you have less B cells being formed. So lack of normal B cells development in the bone. I don't know what this red line is. You guys see a red line down here?
Yeah.
I don't know what it is. It's not something on the screen. Yeah. Maybe I had a little scratch on the thing. I'm not sure. Oh, okay. So let's go to the next one here. Transient hypogamma globulinemia again. So so transient it means slow. Okay, slowly. Transient ischemic attack is a slow ischemic attack. Transient hypogammaglobulinemia is infant slow to acquire, okay, the infant slow to acquire normal immunoglobulins. So, what are the two, what is the immunoglobulins that babies get from their mother automatically before birth? Which one? Anybody knows?
What was the question?
What type of immunoglobulin the mother gets, the baby gets immediately from the mother during development, and they come out with?
Isn't it the G, the IgG?
The IgG, absolutely. So IgG you get, and IgM is the first one that the baby gets from what? From milk, remember? So you find IgM in milk, so they get the milk. And the IgG, they get it through their development. So in this case, so we have infants slow to acquire normal immunoglobulins levels. So the infant have an issue trying to acquire normal immunoglobulins levels in general. So, okay, how many different types of immunoglobulins that we know of again? Let's name them together. IgG, IgA, IgM, and then what?
IgE
IgE,
and IgD.
IgD, okay. IgA. Is there an IgB? No, we don't. You have IgE, IgG, IgA, IgM, and yeah. So B cells. So okay. So these are in the transient hypogammaglobulinemia. The infant have an issue trying to get all these immunoglobulins. Common variable immune deficiency. This one also, you have the person have low titers of immunoglobulins, especially IgG, IgA, and IgM. B cells cannot differentiate into plasma cells. So again, we have issues trying to differentiate. So this is referred to as what? Common variable immune deficiency. So variable, that means I have more than one. In this case, I have G, A, and M. Good? Low titer, not absolutely nothing. What does a low titer means? Low amount, right? Low amount. All right, DiGeorge syndrome is the deficiency of what? T cells, right? Or is it B cells?
It's T cells.
T cell.
Okay. All right. How far are we? Are we almost there? Yeah, we're almost done. Good. I was afraid. Okay, so let's finish up this one here. So we have secondary immune deficiency disorders, factors. Secondary now. The primary, we did the primary before, right? These are primaries. Now we're going to go. So how many primaries did we cover? We covered a couple. So we got this one here combined. We've got DiGeorge, chronic. We have the B cells, IgA and B. And we have another B cells, transient and common. Now the secondary immune, what does secondary means?
Due to something non-genetic.
Absolutely. Do something else, you know, so that we're getting this, do something else, some other factors. So excessive or defective neuroendocrine responses. So in this case, we're not getting some good neuroendocrine responses. Excessive, defective, or others. So excessive, when do we get more? When you, okay, excessive in this case is when we increase a certain factor that leads to immune deficiency. So when we increase corticosteroids, right? We know that, don't we? We said corticosteroids are anti-immune, and in this case, it increases the susceptibility to infection. You agree? If your immune system is down, you become more susceptible to infections. Defective. If you have low corticosteroid increases susceptibility to autoimmunity. So low steroids can lead to susceptibility to autoimmunity because you start building antibodies against yourself when you have low steroids. And the opposite for high steroids. Now, what about poor nutrition, stress, drugs, surgery? All that can lead to secondary type of, so drugs, corticosteroids can lead to that, up or down, and nutrition, stress, drugs, and surgery can lead to that. All right, let's talk about AIDS and then we're done. So AIDS, autoimmune deficiency syndrome caused by HIV. We know we have two types of HIV. We have type 1 and we have type 2, right? So type 1, that's the most common strain that we get HIV and AIDS from, okay? So initially discovered and termed both LAV and HTLV, okay? I can't recall what LAV stands for. So anyways, this is the strain that it comes from, okay? It is more virulent. What does more virulent means?
It means it's most able to be a virus and attack harder.
Yeah, it's more contagious than anything, right? So this one also virulent means it inserts its own DNA, in this case RNA. It inserts it into the DNA of the human being, of our chromosomes also. So when it inserts it in there, it's very virulent because it just changes, it modifies our genes according to it. Is the cause of AIDS globally. Okay, so type 2, more common in West Africa, progresses to disease more slowly. So lower infectivity of this implies that fewer of those exposed to HIV-2 will be infected per exposure. So which is more dangerous? You know, we're gonna say type 2 is more dangerous, type 1 is more dangerous. This is where it comes from, okay? The simian immune deficiency virus that's the main virus, and it mutates into HIV-1. Like COVID now, it's mutating, you know that. That's why it's very difficult for us to find the vaccine because, you know, the COVID that in China is different than the one we have here in the US. So we gotta find a vaccine that matches this mutation that we have here. So it infects wild chimpanzees and transferred to humans in early 20th century. Evidence that humans who participate in bushmeat, okay? So again, all these animals can lead to all these viruses that we get. It could be eating them, ingesting them, and usually a bat is the source of the problem. The bat infects these animals, and then you eat these animals. Okay, so a bat can infect a monkey, can infect a pig, can infect a camel, can infect, anything that we eat, you know. And in this case, they've been infecting COVID, been infecting this. What do you call that animal that Chinese eat? It was on news. I forgot the name, but it looks like orangutan or
Bat?
something. Huh?
Well, I thought it came from a bat, no?
A bat is the original. A bat causes the trouble, right? So the bat infects these animals, and we eat these. We don't eat bats, you see? We eat what? The other animals that are infected. So in this case, I think there's a orangutan or something that China eats, and they eat the scale. I think they eat the scale as a natural type of food as medicine. They use it as medicine. And that's where the index person came. That's where the first person that got infected came from that person that ate the scales of that animal. I believe it's orangutan. You guys can look them up. I forgot what, but it looks like orangutan. But it has scales on it, and they were eating the scales to heal, for healing process, for healing purposes. All right, so what's the mechanism of HIV? HIV, again, attacks the CD4s, okay? CD4s are T helpers. What did we say T helpers do? What do the T helpers, CD4s, do? They help what?
Don't they like help the B cells produce antibodies?
Yeah, to produce plasma, and then plasma produces antibodies.
Yeah, yeah.
Yeah, so here you go. So if the T helper, if this virus attacks the T helper, who's gonna help the B cells in producing antibodies? No one. So your immune system drops down the drain. You have no help. Plasma cells do not have help from the T cells because it's infected. All these T cells are infected by this HIV virus. So you can't produce antibodies anymore. So CD4 is what we actually screen for when we test you if you have AIDS or you are only HIV positive. So if you reach anywhere below 200 count within 1 millimeters per drop of blood, then we say you're going into AIDS now. So as far as it's above 200, then you're fine. You're just positive for HIV. You can cause some symptoms, but you are contagious though. So here we go. Here are some of the disorders that we can get. So when you get AIDS, now you have a bunch of different things. So your CD4s are below 200. You're no longer just a carrier. Now you're sick. You have the disease. So HIV infection plus the onset of other infections equals AIDS. So all these, that picture right there gives you the other infections that you can get. So when you get all these things here, along with, so common type of opportunistic infections would be tuberculosis. You can get TB, chronic diarrhea due to C. diff. You can have chronic pneumonia due to pneumocystis carinii pneumonia, which is a parasite. Fungal infection like cryptococcus that goes into, it becomes thrush in your mouth, and then you end up having Kaposi sarcoma, actually. So Kaposi sarcoma is one type of cancer that is caused by HIV. So you have to have HIV in order to have Kaposi sarcoma. AIDS progression, first of all, asymptomatic like COVID. Virus is reproducing usually for several years, up to 8 years sometimes. Infections begin at the viral number rises, destroying the CD4s. Progression takes 3 forms. Either you go into immunodeficiency or you go into neurological dysfunction. Or you can have both. So here's your primary infection, flu-like symptoms. That's how it starts. Then you go into the clinical latency, and that's usually the period where you show no symptoms or mild symptoms. Then the constitutional symptoms, that's when you start losing weight and you have the OIs being attacking. At stage 4, you get AIDS, and now that's where your CD4s are lower than 200. So HIV antibody rapid test, like we're trying to get here for COVID. A rapid test is a fast test that you can get the result immediately. Usually it's it depends on the test, but now they say it's like 98% good, this antibody test. So antibody testing, rapid test, home test, and then you have the polymerase chain reaction, so PCR. And the PCR is the one that we take in and we multiply the DNA over and over to see if you have the antibodies or not. So antibodies are proteins, basically. So we take your proteins and we magnify them and we multiply them over and over in a machine that's called PCR. And then eventually we'll be able to, what we call electrophoresis on them, to come and separate them in order to diagnose if you have this antibody or not. So AIDS classification, again, like I said here, laboratory finding, if it's if it's over 500, you're not, you're in category 1. If you're between 200 and 499, you're category 2. Category 3, you're below 200. So category A, when you're above 500, you're asymptomatic. B, just to some less serious manifestation of immune deficiency. And C, you have AIDS. AIDS treatment, there's no cure, but we have some drugs for it that you can suppress the virus multiplication. It's called antiviral therapy. And these are the ones that they were trying to use now these days to see if they work on COVID. Nothing major actually is working out of that. So may have to change regimen due to the viral adaptation. Like here it is, COVID changes its mutants, so very hard for us to come and find a regimen for that. A regimen is a multiplication, like poly drugs. We have a bunch of drugs as a regimen. A regimen is a bunch of drugs together to become a regimen. So we have other medicine, vaccines will be used to prevent opportunistic infection as needed. So you treat the symptoms as they come, like we've been treating these patients with COVID, but it's not very successful. Vaccination is good. Transmission prevention also is the best. That's why, social distancing and all that is very good. Washing hands and all that is very good. So we have what we call antiretroviral drugs, ARV, because HIV is a retroviral that goes back to DNA, from RNA back to DNA. We'll talk about these when we get to antiviral drugs in pharmacology. Highly active antiretroviral therapy. These are the combos right there. So you have combos. You see those drugs right there? These are reverse transcriptase inhibitors because, again, HIV reverses itself. And we actually use these drugs to block the reverse reaction that it takes. We can use protease inhibitors also. We'll talk about the different types of the mechanism of a virus, how it attacks a cell by either it's a reverse transcriptase type of mechanism or protease enzyme mechanism, the fusion mechanism that the virus will have on the cell. So these are the different drugs that I'm not going to ask you on this test which drug is which. But for sure, when we get to antiviral, you need to know these things. We are done for this test. So any questions? So I will have tutoring tomorrow at, what did we say? 9 a.m., right? So tomorrow 9 a.m. This test will be on Thursday and Friday, correct? And yeah, go ahead, Aaron.
Sorry, go ahead. I had a question, but finish up. I'm sorry.
No, that's okay. I was just, so stop sharing here. Okay, yeah. Okay.
many questions is the test?
The test is, I don't know. I think it's 60.
Okay.
So we will review tomorrow. We'll go over some of the, the focus points, and we will look at try and study today a little bit, and go over some of the, at least the study guides if you haven't done them, and the focus points as much as you can. But I'll review it with you tomorrow at 9 a.m.
Okay, I actually have one more question.
Yes.
For SCID, the severe combined immunodeficiency disorder, what is the inheritance trend for it? Is it an autosomal dominant or recessive or X-linked?
Let me go to the PowerPoint here and see what.
It said it was inherited, but it wasn't specific of which trend it was.
Yeah. Honestly, I don't know here.
Okay.
I don't know. But if you get something, usually it's more dominant if you get it immediately, like from a parent. So in order to get something dominant, one of the parents have to, if the parents is showing the symptom, the characteristics, you get it and you show it. Even one person can do it. But if he's not showing it and your mother is carrying that also, okay, then both of you, you will get it for sure. So it depends on, but a dominant gene is usually shows the characteristics.
Right. But what about for SCID itself?
I don't know if it's, and I'm assuming it's dominant, but we can look it up real fast here.
SCID is inherited as an autosomal recessive trait or X-linked trait or an X-linked trait.
Okay, so it's autosomal recessive, so it's not going to show in every generation. So both have to have it in order to show.
Okay.
Yeah.
Thank you.
Thanks to all of you for being active and participating in doing this. All right, good job, guys. So we'll get it done. So, all right, so I'll see you tomorrow, okay? And we'll go over some of the questions on the focus points. All right, anyone else have a question before we go?
So just a quick recap of what's due the day of the exam. Is it just the focus point? And
the study guide. I gave you the answers for them, but try and put them in your own words, kind of. So
okay,
read
the focus point study guide.
Yeah, the study guides and the focus point. Is there a case study also there?
Yes.
Yeah, there's 4.
So the case study, yeah. So 3 things. So case study. So anyways, you have until Friday. How is that to do all that? So it's not tomorrow or anything. So we're still. So Thursday and Friday, I'll open up this test. So you can post everything by Friday night. All right.
Okay, thank you.
Okay, thanks.
Thank you.
Fantastic. All right, guys. See you tomorrow. Bye.
Thank you. Bye.
Bye-bye.